Welcome everybody to another Digital Dispatches. For those of you who don't know me, my name's Claire Bushner, and in the DHC operating model, I have responsibility for digital comms, which Digital Dispatches falls under the umbrella of. I've been sort of out of the system, AWOL, for a few what seems like years and years, but actually it's only months and months. Working on the vaccination program, so it's nice to get back to some other things and listening to something that's not vaccinations, or dare I say even certification, which is the big thing in the last few days. So we've already had Digital Dispatches, and I've had really good positive feedback. The sessions are recorded, so people who can't make it can watch at a later date, and it's been really good. We've had plenty of contributions, because this is about putting a webinar, I suppose, or together that the system want to learn more about and contribute to. So we've had plenty of suggestions in from previous audiences about things that we could include in future Digital Dispatches. That's really good. And next month's, it's hard to believe that next month is August, but next month's Digital Dispatches will be Alistair, who works on the shared services programme, coming to give us an update on that. My Windows has just told me that I'm about to be signed off, so I will do a quick introduction to Gill, who you're very welcome, Gill. So Gill, I'm sure, does not need much of an introduction to the people on this call, but Gill's the Innovation and Quality Improvement Lead in the Northern Trust, and also an IHI Fellow, and Gill's going to give us her insights of the programme that the project that they put together about virtual hospital visiting today. So something close to all our hearts, and a really piece of innovative work that went on, obviously, during COVID, and potential use cases, I suppose, as we move forward and use technology in a more innovative way in the coming months and years. So Gill, I will put myself on mute and hand the microphone to you, so to speak.
Great.
And
okay,
you go on ahead.
I'm just going to share my screen here. So hopefully everybody's seeing the slides okay. Yeah, good stuff. Okay, so as Claire said, I'm going to talk about virtual visiting in the Northern Trust. I suppose up front I would say I did not do the donkey work for this project. It was done by a member of my team, Stephanie Kelly, who unfortunately is off sick at the minute. Otherwise, I would definitely have had Stephanie here during this presentation. She is much more steeped in it than I, but in her absence, I'm sort of stepping in and covering the presentation, but the work would not have been done without Stephanie. So just to say that at the outset. I'm going to give you a wee bit of context first around why we had to do what we had to do. Probably seems fairly obvious. Everybody knows what the situation was with visiting and COVID. Tell you a little bit about what we did and how we applied improvement science to it and what we learnt, and I suppose where we are now. So I suppose the challenge, everybody would know very well, COVID-19 restrictions on visiting and maintaining contact between loved ones and patients. So that was the challenge that we were faced with. And I'm going right back to Surge 1 here. So in Wave 1, this was something that we started to do in the early stages of Wave 1. So our aim was really to adopt a suitable technical solution and the processes that would sit around that to maintain that family presence. And we wanted to do it using a method for quality improvement and to implement virtual visiting on our COVID wards and in ICU in the first instance. So that was what we set out to do. As the approach that we deployed to it was a quality improvement method, and I have to say, without the input of Stephanie, who is a senior QI advisor in my team, that would not have been possible. So Stephanie very much provided that rigour to the process, and that has been very helpful in terms of us learning as we went and then being able to capture the data as well. We started off using Pexit as our platform. Now, that has altered since, but at that time, that was deemed the most secure. You might remember the time back when there was a lot of debate around Zoom and the security of Zoom, and there were some anxieties about the use of that. And so we went with the Pexit platform. Initially, we used iPhones and have since migrated to iPads, because obviously the bigger screen is a much better user experience. And we carried out, so if you're familiar with quality improvement science, you will know that the model for improvement talks about the plan, do, study, act, or PDSA cycles. So those are the small cycles of change that you use to test if something's working, to study what the outcome of that is, and to act upon it appropriately. And then sometimes when you're doing things, it takes a number of PDSA cycles or ramps to actually get to the right place of the right product. So we had 5 cycles focusing on different issues, and I'm going to cover what they were. So I suppose if I just start with where virtual visiting is at the minute, and then we'll go a little bit backwards. But we started in March 2020, and we started with iPhones and Pexit, as I've mentioned. It was initially only intended for COVID positive wards, but has been extended due to the restrictions on visiting generally. We then transitioned to Zoom over a period of time, because we actually felt that that was a better and easier platform for staff to engage with. We trialled it for a week initially, and then we had to streamline processes, and I'm going to talk a little bit more about that. And in the early days, a lot of our concentration of activity was in ICU. As you can imagine, that was where our sickest patients were. That was where the biggest need was for that family presence. Many of those calls were last contacts between families and loved ones. So it really was incredibly difficult. But as we stand today, we now have virtual visiting across the service. I suppose we are looking at as a means of maintaining family presence and an integral part of any visiting strategy going forward. Now, that does present some of its own problems around the support that is required to staff in the wards to make it happen. But you can see, you know, we're in all our wards in Antrim, Causeway, we're in 5 wards, Hollywell, we were in Mid-Ulster. Originally, we were in Originally, White Abbey wasn't actually even in the scope, but because it moved to Nightingale status, it was brought in, and then we rolled out our community hospitals separately. So we have coverage across the piece. So the lessons that we learnt, I suppose, and this is really structured around our PDSA cycles, were that in the first instance, we started with a pilot or a test area. So our initial test area actually was one of our COVID wards, though probably where we learnt most was in ICU, I would say, because that was where we had the greatest need. So we were very quickly moving into ICU. But in the early days, we were ensuring that the mobile devices and the platform would work well on the pilot wards. So really that the technology was going to work for us. It was really one of the things that we also found that we had to do was identify a champion on the ward to help test and carry out a series of tests. And really without those champions, it's incredibly difficult, because we did find there was a very heavy reliance on Stephanie supporting staff in the wards. And you would think that everybody is very familiar and tech savvy and, you know, used to using Zoom and all that kind of thing, and it wouldn't be an issue. It's actually quite surprising when you get into that environment. And I suppose when you think about the emotionally charged environment that we were in and the importance of some of these calls, there was a lot of nervousness around getting it wrong, particularly where it was ICU. There was a lot of nervousness that, you know, it would be even more upsetting for the family if they couldn't get the call connected appropriately. So what we found in the first phase, certainly, or the first PDS cycle that we did, was that there were some connection issues. And there were user issues regarding permissions. So there were some things that we had to iron out from a kind of IT InfoGov type standpoint. And we also knew that we needed then to modify our user guides to provide more advice on troubleshooting. So as we moved into our second cycle, which was really looking at moving beyond the pilot to the rollout, we had to find a way to train all staff in use of devices, and that was very challenging. Stephanie spent a lot of time in the wards with the staff, trying to train staff, but obviously you can't capture everybody, and then there's agency staff in and out. So we did have to rely on some cascade training there as well. So not everybody was available, and cascade training was deployed. Staff didn't always feel confident about using the system, and originally we were using our own trust email addresses as well, and that was something that people were uncomfortable with. So we actually developed better training in response to the feedback that we got, and we set up a generic email account that was used then. So very quickly we were in the ICU because that was where the greatest need was. And I suppose one of the big challenges there was getting the buy-in from staff in ICU, because you can imagine in the height of the first surge, people were still getting to grips with all of the PPE done and often. A lot of staff redeployed, new teams coming in, obviously dealing with the whole anxieties around COVID patients and the volume of work. And our ICU unit moved 5 times in physical location as well during phase wave 1 of COVID. So a lot of things to deal with, and then here we're coming in and asking them to do this as well. There was a lot of support given by our team to support those phone calls with the families in the early days, setting up the app, making sure. Usually there was a test call with the family beforehand to make sure all the connections would work before actually it would involve the patient. Because there was a really high anxiety about getting this wrong. It was so important, particularly where these were end-of-life calls. And then we found that the staff carrying out the virtual visit and spent a long time with families getting the app set up. So that was just down to their familiarity really with it. We were fortunate then at that stage that we in the Trust had set up a family liaison team. So this was the team in the Trust who liaised with families about their loved ones. So there was a system every day where there was a number of calls made to families. There was a system where families could drop off personal items for their loved ones in the wards, and laundry could be left for them to take back home. And the family liaison team were also very present in ICU, maintaining that contact with the family. And so we were lucky at that point that the family liaison team stepped in and helped us support the staff and the families in advance of the calls. So then our 4th cycle really focused on hearing issues. Now, again, because you had the whole issue of infection control, in the early days we were double bagging these small phones, and you can only imagine when you do that it starts to affect the sound. So staff were reporting that maybe there was issues around the sound quality, and it was because of the double bagging, but that was to do with infection prevention control guidelines. So we actually spent some time working with IPC and looking for cases that would pass the infection control standards that we needed and be suitable for use in the wards for our iPads. So that was something that we were able to source, and this definitely resolved the issues around hearing, and those then were sourced for all of our devices. We then had some issues with, I suppose, seeing, because again on the phones it's a small device, and the staff were reporting they were too small, and patients, maybe some of the more elderly patients with sight impairment, were finding it difficult. So we were able to get some iPads, and I suppose in the early days in COVID, I mean, those of you involved in any of the IT procurement will have known it was very difficult actually to source iPads. Everybody was wanting these devices. Now, we did get some donated devices, which we were able to trial, and then as stock became more available, we have since upgraded all the phones to iPad devices, which are working much better. But it wasn't an issue with stock in the early days, certainly in terms of trying to actually source that stock. So what did we learn? I suppose this is really the crux of it, isn't it? I think what we learned was that without that senior input at a quality improvement level from Stephanie, we would not have had that learning, kind of agile learning system that we had, and the ability to adapt what we were doing and move very quickly. And also there was really a need for a lot of hand holding and support in the wards, and that really consumed a huge amount of time. We did have to rely on training by the person who was designated the lead in a ward to try and cascade some of that, because it just wasn't possible to get around everybody. The family liaison team coming in definitely was a big help to us. The problem with that was it's not a sustainable solution. So as we have moved out of the latest surge, we no longer have the family liaison team in situ. But yet we have now created this need for virtual visiting. We have published, we have promoted it very highly. And there's still some issues around staff feeling they need a wee bit of support and patients on the ward, and we don't really have a sustainable solution to that. And that actually is a problem across the region for all trusts. We did create a lot of user guides, troubleshooting tips were really necessary, and we really had to streamline documentation. I suppose what we found is we produced a lot of tips and guides and documentation, but staff didn't read it most of the time. They just tried to feel their way through it. Infection prevention control input was essential because we had to not just worry about the issue about the double bagging and all that, but there was the cleaning of the devices between use as well, and the amount of time, lapse time between uses, devices, etc. So it was really important to have their input to that, and having a champion on the ward was absolutely essential. Where we didn't have those champions, what you saw was the utilisation of virtual visiting was low, and that was because there wasn't a need for it. It was actually just because nobody was really championing it, pushing it, and publicising it. There was so many anxieties about getting it right, as I mentioned, particularly where these were end-of-life calls, and there was some resistance in the early days. The iPad was favoured over the phone for the obvious reasons, and I think I've mentioned at the outset there the scale of the implementation that we now have. We also had to put in place psychological support for staff who were making the calls, particularly those people who were making those end-of-life calls. You can imagine how traumatising that was for those staff, and particularly when they were working in this highly charged emotional environment, and had a lot of anxieties themselves about, were they appropriately protected and everything else. So that was essential, and we worked with our psychology colleagues to provide that. Families really appreciated putting a face to the staff names, because prior to that they would have been getting phone calls, particularly if you think about ICU where somebody's in for a very long time. They would have been getting phone calls to say, your mum is, or your dad is, or whatever, and this is so and so. They would have heard the name, but it kind of dehumanises it. Whereas when you can put a face to that name and you recognise that that's the face that is caring for your loved one, it's very, very important. So that was really appreciated. It was a really important intervention for families to say goodbye, and a really important part of that grieving process. And we learned so much from the first wave that, when we were hit again in subsequent waves, although the activity in virtual visiting would have dropped off a little bit once, we were allowed to have physical visiting again, we were able to step up our processes again quickly because we had all that learning. Equipment was a bit of an issue. So I've mentioned about the sourcing of devices, and in the early days not everybody had a device. We had to share some devices, and that presented other problems around, again, infection prevention control and managing all of that. We worked in the early days about basing it on need and working with the existing stock that we had. The double bagging I've mentioned. Everybody now has this iPad mini with the waterproof sleeve, which has been passed by IPC, and they don't need to be double bagged, and the volume is so much better. Engaging service users, in the early days there was not an opportunity to engage with service users around the design of virtual visit and how could we. It was really just, we need to get this up and running, and we need to do it really quickly. And also, if your loved one's in ICU, you just want to be able to communicate with them. You don't want to enter into a conversation about how that's going to be designed and all the rest of it. It's just, you need it to happen. So it was difficult, it was challenging, but as we moved through the process, we were able to get some, I suppose, more sporadic feedback from through the family liaison team and ICU staff around how the families felt this was working for them. We are now trying to add it to Care Opinion, so that on all our tablets and virtual visiting, there'll be some way of capturing that feedback automatically through Care Opinion, and that's something that we are looking at. And we have service user guides, which we have trialled and are on our website. So the little pictures in the bottom here, you'll see this is one of these is our helpful guide to online visiting in hospitals, and the other is about how you install Zoom. So lots of guides were required, but as I said, not always read. They felt their way through the process. We produced this very simple little infographic that's in the middle here, how to set up a Zoom virtual visit. We produced a step-by-step video, and all those resources were available on StaffNet to staff. And then more recently, we have produced resources around for service users around virtual visiting as well. these are some stats now. These are not up to date, and I do apologise for that. And that's really simply because the team is so depleted at the minute, and I didn't have time for this presentation just to get the updated stats. But I suppose what you can see here is Pexit is the orange, and Zoom is the blue. And annotated on this graph are where we had, significant, I suppose, changes is what I would say. So you can see that once we got into it, the things started to step up, particularly in ICU when we're in the height of the surge, which, we knew that was around that April, May time. And then you can see things falling off, visiting rules relaxed, and then as we entered the second wave of COVID, and we moved into the use of Zoom, you can see how the use again has increased. And as we've rolled it out across the trust, that has increased exponentially in line with that as well. Having the family liaison service on the wards, we do see that promotes access to virtual visiting. There's the staff are more confident, and there's more time to talk to the patients about it as well. So some of the qualitative feedback, I suppose, it's just interesting to look at this. We had families who were standing outside our ICU. It was on the ground floor in wave 1, and we had families who would have stood outside the window and be able to see, their loved one through the window, but actually to be able to hear their voice through virtual visiting was such a comfort to them as well, particularly when it was end of life. And lovely to see mum with her own eyes. And it was for the staff an experience that the family, really connected with the staff when they could see the faces of the people who were really caring for their loved one. That was so important to them, because it was humanising a situation which, was something that none of us had experienced before. And it was great for the staff then to see the relatives on the screen too, because these were talking to these people sometimes several times a day. So to be able to put a face to it again just made that human connection. So I suppose in terms of where we are now, staff engagement can still be challenging. It's difficult. People are busy on the ward and continue to be so. And also you have new staff rotating through the system all the time. So it's just an ongoing thing. And, at the minute, without the family liaison service, and unfortunately that's definitely not in my team at the minute, we don't really have any ongoing support. So we really are relying on the wards. And I think that we are missing that ongoing support. We've really promoted virtual visiting through StaffNet and with frequently asked questions, and we have our video on how to set up a virtual visit, etc. We've done external advertisement of it for service users, and there's a service user poster, leaflet and guide, etc. It is difficult to capture user feedback. I mean, particularly in those early days where some of those calls were very unpleasant. You cannot go along to somebody afterwards and ask them what was your experience of the call. It's simply just not going to be appropriate. So we do need to get a robust ongoing means of trying to capture that, and that's where we're looking to with Care Opinion. I suppose to round it up, every trust, we probably got off the blocks really quickly in Northern Trust with virtual visiting, and everybody had to do it. Everybody had similar models, I would say. Everybody struggled with support on the wards, as we have had, and we've all muddled through with different support mechanisms around that. There was, through our COVID learning that we did through HSCQI, we agreed that virtual visiting would be a regional priority, and the initial aim was for everybody to have it in, I think it was 2 or 3 wards. By that stage, we were probably 70% coverage in Northern Trust, but everybody now has obviously gone between more than the 2 or 3 wards, and everybody has a significant level of coverage. We developed common resources then, so we work collectively as QI leads to look at, well, what's the checklist of things that you need to have in place if you're setting up virtual visiting? What are the things that actually need to be in place, so that we could bring some standardisation to the process? And we've had ongoing learning and sharing. So we used Echo to run a series of calls just around sharing and learning, because we were all at different stages. It was about trying to learn from everybody else around what had worked well and what hadn't worked well, and the pitfalls, etc. And those kind of continue. So I think that's maybe my last slide. It is for us, I suppose, we continue to have virtual visiting as COVID restrictions relax and visiting opens up. You'll probably see it drop off again. I do think, however, if you think about dispersed families, like people who have relatives all over the world, using virtual visiting is something that just needs to be part of a unified visiting approach, I think, going forward. So it's not, I don't believe it's COVID specific. I think COVID drove it, but I think it's something that we are going to certainly retain. But we do have some issues, as I said, just around that kind of sustaining it on the wards. And I will stop the share there, Claire, if that's okay. It's just so I can see everybody's faces properly again, and then really happy to take any questions or conversation.
Thank you. Thank you, Jill. I am glad to say I have just received an email into my inbox to say I'm getting a new PC because it shut down in the middle of all, and now I have the spinning wheel of doom. So hopefully you can hear me. So the email saying that I'm getting a new PC was greatly received this morning. So thanks, Jill. I mean, I think it is a really true example of, you know, like we have done, I suppose, across the board in COVID, you know, responding to a need. But I love that word, humanising. You know, visiting hospital and especially visiting ICU when you can go in person is not a particularly nice thing to do. It's quite scary for families. But actually having a relative in, you know, intensive care during these times when you couldn't get to see them must have been even more of a stress. So, you know, a true response to Nadine, truly person-centered. And isn't it strange that in our normal non-work lives, something like Zoom that we take for granted so much, you know, calling relatives, FaceTiming people, when we transition that into work life, it's, you know, it can be difficult for staff. So it was good to hear about how staff were supported. I am presuming that some of the names on the meeting today are people who were potentially involved in this project. Do you recognise? I recognise some names. So are there people on the call who were involved in the project who would like to make any comment?
I don't know if James, whether you wanted to chip in there and say anything, and Neil's obviously on the call from Northern as well, so they may want to add something.
Yeah, I think you described it well, Jill, and I think it was successful. And in a sense, there was also an exciting element to it. I mean, it was obviously a tragic and difficult time, but the sense of being able to see innovation happen quite quickly and get something in was quite stimulating to be. I wasn't directly involved in much of it, but around the edges of it, at least, it was interesting to be a part of. And my other reflection on, and you mentioned this, Jill, was just the information governance rules being relaxed. I mean, pre-pandemic, we would never have been using Zoom, of course, for anything clinical. And it really did move the goalposts at the ICO and then more locally at a trust level and through Neil, that there was a clear permission for people to innovate and use things that previously we wouldn't have been able to. Just totally changed the landscape of it. And I hope that we can somehow hold that in a post-COVID time. You know, that there's room, flexibility around that in some ways, but I think that was important.
Yeah. Anybody else have any comments? I totally agree, James. I suppose maybe we could say we've got away with a wee bit of flexibility, as you politely put it, during COVID. But I think we've proven, and stats have proven it, and even the qualitative data has proven that, you know, those things that we've spun up and that we've done and, you know, and done differently to what we would normally have done in normal times, you know, have been very successful. And I would be with you that we could hold the line and continue to work in an innovative and iterative way to make things better. Because, I mean, as Jill said, you know, you don't want to go back now. You know, for those relatives, you know, if you think, you know, for those relatives who have family members who live remotely, you know, in Australia and whatever, you know, why would you go back? Why would you go back now when you've got this type of technology and have proven that it works very well and is a very positive experience. So I agree, James, that
It's Nadine here from Western Trust. You have just taken the words completely out of my mouth about the remote relatives. I've been on the receiving end of that myself when someone has been remote from someone who is maybe end of life. And I was just going to ask, because I may have potentially missed it because I had to take a call in the middle, but how are you making this part of your long-term strategy? Are you having any difficulty buying people into the idea of virtual visiting as being not necessarily COVID specific, but long-term?
I think probably everybody initially in the early days probably thought this is just something we're going to have while we're in COVID. I think the fact that we put so much effort into the resources to support it, as in the guides, the video, the practical support, all of that, I think there's probably an acknowledgement that it's here to stay, but I don't think we have a sustainable model for it at the minute because, as I said, there is this issue about needing to have some support and presence, I think, on the ward, because don't forget, there are people who admitted to hospital who have their own devices, like ourselves, could make a Zoom call, no bother. Those are not the people we're worried about. The demographic we're trying to support here are either the very, very ill people who we had in ICU, or maybe the more frail, older people who might be in our respiratory wards who, not familiar with using a mobile phone, setting up a Zoom call. So, they need that. And then for the staff, I suppose that's a call on their time whenever they're run off their feet doing lots of other things. So I do think that our ambition would be that it is part of a unified visiting strategy going forward. I don't think as a trust yet we have quite worked out the solution to that particular ambition, but we've no intention of pulling virtual visiting out. It's still there, and just because I haven't had an opportunity to look at the most recent stats, I don't actually know what the utilisation is, and that's probably going to be quite helpful to look at that now that we're returning to some sort of more normal business, if we can ever call it normal again. But I don't know if Neil wants to come in there maybe and add anything, Neil.
No, Gill, just thanks very much for the presentation. I thought it was great. It really did set it out very well. And James's point is good as well. It was a bit of a leap into the unknown, I think, when we sort of said, you know what, we need to deliver services, and that's the most important thing. And if we're doing that in a way we didn't do it before, well, let's try to understand that risk and move forward. And but you know what, the sky hasn't fallen in, and actually services have been delivered very successfully. And our ICO notifications recently have been nothing to do with virtual clinics or Zoom. It's still people leaving patient notes in the bits of cars. Those problems haven't gone away at all. In terms of the sustainability, I mean, it's true with virtual visiting. It's true with a lot of things around COVID. These things were put up very quickly, often with staff who were redeployed from other areas. Clearly, there's no recurrent money behind it, so it's a struggle in lots of areas to keep these things going now that staff have moved back to where they started from. So it's one of a lot of things that we need to get our head around as to how we do it in the future. But you're absolutely right, Gill. It's not something we would want to lose. Even if it's, the people who have relatives across the water or whatever, they it can, even in a post-COVID world, it's still a really useful tool to have in our armory. It's not quite so universally required. It's still a helpful thing to have. So we still need to work out how to do it long term. Absolutely.
Yeah.
I see a question. Sorry, Claire. I've seen a question just in the chat here from, I think it's Brendan, around the use of personal devices by patients who don't need any help. Does it present any network challenges? This was one of our extreme worries in the early days. Brendan, is our network going to fall over, with the volume of stuff? And of course, we all worried about that, didn't we? Because we were all doing everything virtually. And of course, networks were never built for the amount of demand that we started to put on them. We didn't have, we counteracted any issues. I suppose there were places where we knew we maybe had some issues with Wi-Fi, like Nightingale, for example, but that had to be addressed anyway. So where we knew we had issues, we were able to address them. And we didn't encounter any issues with networks falling over. Sometimes, like anything else, of course, the Wi-Fi can be a bit slow depending upon how loaded the network is. But generally speaking, that hasn't been a particular complaint really with anybody, and certainly we haven't had any really big incidents from a technical point of view, thankfully.
Jill, just put in there. Would they be? They would have been using your BT, your free Wi-Fi. They wouldn't have been using your network. Yeah. Just to make it clear.
Yeah, would.
And Claire, could I follow up maybe with Neil then, in the sense of, we have issues sometimes with patients using their mobile phones and recording activity on the ward and things like that there. So we're kind of tipping in then to another governance issue. And then from Alex, Neil, is there any thoughts you have or any considerations, maybe not in COVID because it was well controlled, but if we were sort of moving forward to try and keep this a reality, and how we would support it, as part of that sustainable model you're talking about? Do we see any challenges coming through there where there's maybe more free use of a personal device, and the potential misuse of that device on a ward?
I guess that is a challenge, Brent. I mean, we're not confiscating patients' mobile phones when they come in through the door, so there's nothing to stop you, to stop them taking pictures of people, other than the staff telling them, no, we do not do that, please. So yes, it's a challenge, but it's not really COVID related in that sense. It's just the fact that now everybody has a camera in their pocket. So yes, it's an issue, but it's one that we deal with at the front line on the wards, at that level.
I suppose I didn't say, and I should have said, that our devices for virtual visiting are locked down in terms of they're only useful for that purpose. The camera to say, you can't be doing things, using the device for other things other than virtual visiting. The guidance does provide a guidance around adherence to privacy and all that kind of stuff, but of course, as Neil says, you can never police that completely, but it's a wider problem than for virtual visiting, I suppose, and it was very sensitive. Like, that was this very sensitive issue in certain areas, like mental health, for example. It was really sensitive in that area. So there's some areas where it's a bigger sensitivity than others as well, I think.
Thank you.
Anybody else got any other comments or questions? No. Okay, we'll end digital dispatches for the 2nd of July on a very positive note. And I was thinking there when we were talking about during COVID, and for those people who have relatives overseas, but even for something as simple when a ward is shut down because of, dare we say it, the dreaded D&V, or so there's more bog standard reasons why people can't go and visit, isn't there? As we march into normality, there'll be other, and of course a very similar thing was rolled out in care homes as well, of course, over the pandemic, through the Frailty Network and NHSCT. They did some work on the care homes, and it's being taken forward by a subgroup in another piece of work now about trying to continue that, because like Gill said, being very, very positive, and we all saw the horrific pictures on the TV of relatives, as Gill described, looking through the window of ICU. I just lived down the road from a residential facility with people with learning disabilities and older mental health, and it would have broken your heart seeing the relatives driving into the car park and standing at the windows over the weeks. It was so lovely to see them a few weeks ago being able to go. They used to walk to Tesco's every night, and it was lovely to see the staff bringing them, being able to go to Tesco's to get their goodies again. So there's lots of use cases across the board, not just in a hospital trust. So long may the innovation continue, and staff keep having the ideas.